Hello, so I'm Victoria. As Anne's just said, I'm consultant epidemiologist at UK Health Security Agency, and thank you for having me. I'm hopefully check the pointer. Okay, I'm going to talk a lot about SIREN. Okay, so I'm going to start with a bit of an overview about the study methods and in particular what data we're collecting, because a key feature of what we're doing now increasingly is thinking about collaboration. So I want you all to leave here knowing what data we've collected in case it's something that you would be interested in looking at and analysing, and really open to you coming and talking to us. Then I'm going to talk a little bit about the headline analysis that we did, which has been really monitoring protection from SARS-CoV-2 throughout the pandemic. And that's what we were set up to do. So I'm going to talk a little bit about the story, and it's what colleagues, Anne and Peter and Daniela and Chris have given us support in over the last 5 years as well. I'm then going to sort of switch tack a little bit and talk a little bit about the challenges and learning from running a pandemic cohort study and thinking about what learning we might have for other studies getting set up. And then I'm going to be focusing at the end, looking at beyond the pandemic and what work we are doing now and have been doing for the last couple of years. So let's start with what is the SIREN study. With a nice photo there of Susan Hopkins, who is the SIREN study chief investigator. So SIREN was set up really very early in the pandemic, and it was recognizing when we had this new pathogen emerging that there are a series of questions that we really needed to rapidly answer. And the key question that SIREN was set up for, and it's very clear from its title, SARS-CoV-2 Immunity and Reinfection Evaluation, was, does previous infection protect you from reinfection? And if so, for how long? Okay. But obviously, a key feature of the pandemic was that rapid development and rollout of the vaccine, which sort of changed quite quickly the landscape. So quickly we pivoted and adapted the study to become a real-world vaccine effectiveness study as well. And so that was a co-primary aim. So the design of SIREN then, it is a multi-centre prospective cohort study. This map here shows all the different sites that originally signed up to SIREN. So that was 135 hospital sites, which in England are the unit of a trust, but it's slightly different terminology in different devolved administrations. The other key thing is we are a 4 nations study, which was a really important part of how we've worked in collaboration across the public health agencies. And really, we've been looking at continuous data collection since our start, which was in June 2020, when we recruited our first participant. So in total, we recruited about 44,500 participants for 12 months of follow-up. And just giving you a bit of an overview, we're really a working age cohort, a median age of about 43. A predominantly white in terms of ethnicity. We had a real range of different staff types of people working within hospital settings, but you can see largely clinical, but we did have administrative and others and support. And then we also have quite detailed information that's breaking down those roles in terms of different clinical roles and also in terms of the setting that people are at. So really quite a rich source of data, and particularly for that first year where you've got a really high volume of participants providing information. As I said at the beginning, it's looking at 5 years. This is the SIREN study at 5 years. We have been running now for 5 years, and this is just giving you a kind of a flag, and I think just highlighting, whilst it's been the original cohort of 45,000, we've had different iterations of the study. So initially it was 12 months, and then we extended to 24 months. We then sort of added a 3rd year, and then we did the last 2 pushes have been around really the winter period. Okay, and so that's really, if we look at that kind of key point about when we've ended it as a the pandemic was sort of declared over by the WHO, you can see that we've continued data collection in these time points with SIREN 2.0 and SIREN Plus. And a key feature of that original recruitment was through hospitals, and we did a combination of face-to-face hospital sites going in and recruiting, but we enrolled through an online enrollment. And then when we have then done successive rounds of data collection, we have gone out to our original cohort and asked them if they want to continue to participate. Okay, so everything is based on the 45,000 who originally joined with us. Okay, and this gives you a bit of an overview of the data that we've been collected. So consistently, you've had so you would have started with a really detailed enrolment questionnaire, but we've had a fortnightly survey, which has been collecting data on symptoms and exposures. And that's what we were running, as you can see in SIREN Plus, has just been the follow-up survey. So we haven't had a budget for testing. But a hallmark of the study was consistent PCR testing on a fortnightly interval. And as you can see, for the first few years, this was focused on SARS-CoV-2, but a key shift has been the adaptation and the introduction of multiplex testing to look at other viruses as well. And then another hallmark, in addition to that fortnightly PCR testing, which allowed us to look at infection as an outcome, has been the regular serology being collected, okay? And that has allowed us to amass a very rich biobank of over 400,000 samples from that cohort of 44,000 people sampled over time. And this is just breaking down, as I said, these sort of different stages of the study and giving you an idea of what sort of, what numbers are being followed up in the different time periods. And clearly another feature is obviously the power of data linkage, bringing together lots of those information assets within UK HSA, whether that's the national immunisations registers or data on hospitalisation. So that's another powerful addition that we've got. Okay, so that hopefully gives you an insight into what it is that we've collected and what data we have sitting there. But now I'm going to highlight, as we sort of said, that first primary aim of SIREN, in fact, indeed the co-primary aim, which was looking at protection from reinfection. So what's your protection from infection, your infection-induced immunity, and what's the protection then from vaccines as well? And increasingly over time, it's looking at hybrid protection. So this is a map that really showcases basically that PCR, that fortnightly PCR tracking of our cohort, from starting in June, so the 18th of June, the first patient enrolled in 2020, up until sort of the 31st of March 2024. Okay, which was that's our cut of data, and you can see sort of the different variants across the top. You can see, I mean, a clear, you can see that the Omicron wave hitting, can't you? Because that really, that massive peak that that is showcasing how that was a real departure from the previous trends. So we started looking at the question of reinfection before vaccine was rolled out. So this is what we call interim one. So this was really when reinfection was a very rare event. Starting with 44 reinfections. And we then did our second analysis was looking at that primary vaccine, so the first 2 doses, and it was a data cut in sort of February 2021. So this was a really rapid short-term protection, and that was one of the key studies which was demonstrating how effective the vaccines were. Okay, we then, like many studies, we were looking then at how durable are those 2 doses, and that was so looking at waning protection from the vaccine, which was data that was supporting the decision around rolling out boosters. And then we've then had, no, in fact, that was a fit. This is the booster one. And then we've then had a series then looking at the last 3 rollout of vaccines. Okay. And this is just unpacking here. I think a really key point of the study has been trying to time these analyses to inform key policy decisions. And that's part of, I think, where we've sat within a public health agency and being responsive to the demands. So in particular, the JCVI, which is the Joint Committee on Vaccinations and Immunisations, who were the key sort of expert group reviewing the data and making recommendations which government then took. So the government makes the policy and the experts make the recommendations. And it was really key for us as a study that we were feeding in our latest analyses. Often they would be the interim analyses. Often it's many months before you get the publication out, but it was getting the data to those groups at the right time to inform their decisions. And you can just highlight there some of the red kind of key decision points or key meetings that were being there. And, one of that key ones was that roadmap out of lockdown. We were one of, I think, 3 studies that Boris Johnson mentioned in that speech in sort of March 2021, which were demonstrating the rapid, that impact of that first 2 doses. Okay. But as I said, so obviously those are all 7 analyses. I don't think I should be necessarily calling them interim analyses because they're sort of final now, but those are all linked to papers. But a really important point, I think, for impact it's not the papers. It's about getting those early insights, getting those early slides to the experts at the right time. And actually it was creating surveillance reports. Okay, so this was a key we were a key sort of data source in fortnightly reports, both an initial reports that we ran just from the SIREN team, which went to the CMOs of all 4 nations and others, but also combined into a kind of organisation-wide surveillance report as well. And that data, before you do any more analysis, just the trends are really valuable for kind of situational awareness. So it's sharing early, okay? I think the other point in terms of this kind of increasing impact is also about through research partnerships. I'll talk about that a little later in my lessons, but this was something we did quite early. In particular, we established the SIREN consortium in sort of, I think it was 2021, and that was allowing us, in addition to that sort of public health question and that big scale, it was to really work with colleagues who had more expertise in immunology, had more expertise in different laboratory techniques, to be making getting value out of those samples and really thinking about things like the correlates of protection associated with COVID. Okay. And another point related, in terms of impact, but really linked to that question around protection, is about recognizing the value of that biobank that I talked to. And there's some photos. So we installed some massive freezers in the car park in Porton Down. And they had to talk about logistics of concrete and shipping, all these things, but because rapidly, this is a big volume of samples. But really, those samples and that idea of paired longitudinal sera that's there from a healthcare worker population is a really valuable asset for pandemic preparedness in general. And it was utilized with a number of key in 2023, with a number of sort of emerging risks and concerns. Our ability to go and identify a set of, in this case, different sample sets for different questions allows insight as well. Okay. So I've talked about what the study is. I've talked about that kind of primary focus, which is about reinfections and vaccine effectiveness. But I'm going to talk a little bit now, step back and thinking about challenges, the challenges encountered and the lessons identified. I specifically don't say learned because you never know if you've learned them, but these are the lessons that I've identified and teams identified over the last few years of running SIREN. And I'm going to start as well as highlighting, obviously, a lot of this is from our experience and my experience of running the SIREN study, but it's also been a really, important aspect of the last couple of years has been thinking about networks and collaborations and sharing. Okay, and it's just highlighting actually there were a number of healthcare worker cohorts that were established across the globe in lots of different settings. And back in March 2024, we brought a group of different investigators who'd been running these different studies together, and it was a really great opportunity to be sharing opportunities, challenges through the experiences of running these studies. So the next few lessons are kind of informed by both those discussions. Okay, and through this we've sort of formed this a new network basically of these cohort studies. So I think helpful maybe to recap of what's different. What are the hallmarks of a prospective cohort study? What are we trying to do? And I'm sure for this audience, you all know this, but let's recap because, you want to go out there and you want to recruit your population of interest, and then you're going to follow them up over time and you're going to be measuring things. Okay. And then at the end, at this nice defined endpoint, you're going to be sitting there and doing your data analysis and compare the risk. Okay. But now, But clearly there are challenges that we encountered at all stages of this. You know, some are in general for all cohorts, and some are maybe turbocharged in the pandemic. You know, questions about will we recruit enough? You know, and some of that, you know, will we recruit enough kind of comes back to what sort of outcome is it that you're seeking to do? How rare, how common? The bigger, you know, I've got another slide, that's all right. But you know, what follow up are you going to be doing data linkage? There were lots of studies in the pandemic which harnessed the power of data linkage really powerfully. And that data is being collected, okay? Or are you going out and doing what we did, which was actually getting people to contribute active testing? Yeah, there are different values for these things, but certainly getting people to contribute, complete surveys, do testing, it's pretty expensive and it's resource intensive, and it has considerations. And that links then to how frequently should we test? And then that links, what outcome are we best placed to study? Will we retain our participants? That's the key. If you might bring a big number, but if they drop out, you might lose them before the end. Key question, what if things change during your follow-up? How will that impact people's willingness to stay engaged? How will that impact what you're studying? When will we finish? This was key, as you saw my slide with how many different waves of the study we've got. There's a question, when will we finish? We started saying it was a 12-month follow-up, and as you can see, those same participants have stuck with us over many waves, which is brilliant. So just thinking about that in terms of recruiting enough participants, you know, a couple of comments, you know, I think you've really got to think about the scale. I think lots of what SIREN did with that 45,000 participants, you know, was related to this scale. We set that up because at that point, reinfection, we needed to get that answer quickly, and reinfection was considered to be a rare event, and it was a rare event until we got the Omicron. Okay, so we needed big numbers, and to get the big numbers, we needed multi-centers. But it really does add a lot of complexity, onboarding multiple sites at the same time in a really, you know, short space of time. And bringing participants on. I think you've got to think again by that scale, which is both recruiting your sites, recruiting your participants. You need to be thinking about what are the priorities and the barriers for both your participants and your sites. And that's about this, you know, the importance of ongoing feedback loops. You need to be thinking about your recruitment campaign. You need to think what are your channels, how are you, you know, who's going to be delivering messages. We had, you know, messages from Chris Whitty or the chief execs. That was a big element with the original Cascade and recruitment initially. Thinking about, okay, how are results going to be getting back to participants? So all these things we need to be thinking through. And I think it's really important, that scale I talked about, 44,000, that is in a very unique circumstance, which was a pandemic. And I think this is something we're very aware of with different rounds of testing or sub-studies that we have been doing. It's thinking, you know, you need to be thinking, what's your lens to engage people? Because the pandemic was a really important call to action for lots of people across the country. We've seen mass engagement in research, you know, from all walks of life, but certainly from healthcare workers. But again, it's thinking subsequent asks, subsequent sub-studies, always thinking about what's going to engage these participants or not. And then, so that's really thinking about at the beginning, which is when you're recruiting, but just thinking about some of those challenges that we encountered in the real world during follow-up, you know. So some of these elements, what follow-up and what outcome, it really depends on the money you have available, and it depends on your study objective. So SIREN complemented many other surveillance and research studies that were set up in the pandemic. And what we were set up to measure in particular was infection, which is what we could do by having that asymptomatic testing every 2 weeks. So regardless of whether you were symptomatic or not, you tested. So that was a really important focus for us for the last few years, was maintaining that focus. And I think, again, you know, what we could do with 44,000 again was the extraordinary sort of circumstance of the pandemic. It was also linked to the fact that there was funding made available for staff screening throughout the NHS. So we were sort of piggybacking on other initiatives. We as a team didn't manage a budget itself. for those many, many millions that would have been involved, okay? Whereas in contrast, when I showed you that SIREN 2.0, that was when we had 6,000 participants having fortnightly multiplex PCR. That was a budget that we owned. We organised centralised postal testing to bring down costs and create efficiencies. But again, it's just highlighting, it's that awareness of affordability and scale is connected to that as well. And then just think about, will we retain our participants? So, in SIREN, I mean, the answer for us with SIREN was yes, which was incredible, So we had about 85% retention of our cohort throughout that initial 12 months was 85%. I think the next 24 months, those who stayed with us for a second year, was about 87%. Our last iteration of SIREN 2.0, we had 96% retention. So people started with us and stayed with us, and didn't withdraw. But it's really important thinking about having, that doesn't just happen. That is about having a proactive cohort retention program. That's thinking about how you engage your participants. That's thinking about, the importance of a participant involvement panel, which was something we set up quite early in the study, and the importance of that ongoing feedback. Okay, and active monitoring of your withdrawals, and really being alive to internal and external changes that can impact participant motivation and how that can happen and change throughout the study. And I think that's just highlighting again, the reality of a pandemic cohort study was how much changed over such a short space of time. And I've just tried to list all of these different things that changed over those last few years. And the point is that they all impact potentially the motivation of your sites and your participants to stay with you. Okay, so you need to be proactive about that. And you need to think about how, you need to have that horizon scanning function, but you need to be communicating. Okay. Yeah, and clearly another point is also the funding and the iteration. We didn't approach people and say, do you want to stay with us for 5 years? We approached them saying, will you be with us for 12 months? And they said, will you stay with us for 24 months? Will you stay? So it's a series of sequential asks. But that's linked to the funding model because the funding is, agreed on an annual basis. Okay. And then I was just highlighting, some of these real challenges that we faced and encountered in the pandemic around, the analytical challenges, the complexity and the increasing complexity of hybrid immunity, breaks and follow-up. If you've got a stop in testing, how do you reassign somebody's status around their post-vaccine, post-infection status if you've not had any data on them for 6 months. Lots of things to be thinking about. So my key lessons, I think from SIREN, one of them was being pragmatic. Just to highlight, this was as a pandemic response study. I mean, we had the protocol ethics agreed on the 18th of May. It was 18th of May, and we recruited, 5th of May, and we recruited our first participant on the 18th of June. So it was really rapid, okay? And the key point about this was that we really did, we were building the systems as we went, okay? And we also thought about kind of how did we reduce barriers to entry. We put a lot of flexibility into how we recruited. I've talked about that kind of online enrollment. We made use of the national surveillance infrastructure to pull our testing data. So there was lots of building into what was there, okay? And I think also a key thing is, analyze as you go. I've talked about the value of surveillance reports. It's not just the complex analyses, which do take time. Sometimes just that data on the trend line is really valuable. The importance of, as we sort of said, being pragmatic, systems as you go, how are you sharing data in a timely way? And a key one, I think I've probably already given you examples of this, but is adapt. Yeah, you can't stand still. You can't design a perfect study in a pandemic and then just keep delivering. You have to adapt. You saw on that, even the first slide I highlighted, we were looking at reinfection, but then with vaccination, we adapted and we're looking at vaccine effectiveness as well. So you have to adapt, okay? And that's also why we are still in business, and I'll showcase that as well. Involve participants. I've talked about, that 85% cohort retention. That was because we put a proactive focus on how are we going to engage and involve participants. And a really important aspect of the study was having our participant involvement panel, which we are now on our 3rd iteration. So our 3rd group over the course of the study have just completed and will be about to re-recruit a new group as well. We've also been doing sort of research on this and this paper in particular, which was written with members of the panel was really describing what our process was for building this our SIREN PIP, as we call it. And another point, I keep the slide because I feel very passionate about that, which is care about the how. Okay, and that's about the how you are setting up and running research. Okay, I mean, this is kind of a bit of an infrastructure sort of diagram as I see it of how we've operated our different themes as a team. But it's really thinking, you know, in my mind, it's thinking a lot about the team. I think this is particularly in a pandemic response. There's a lot of command and control structures. I think what works for a research study is quite different, actually, and it's much more of a network team structure. And I think that's how you can promote creativity and resilience. And, you know, so it is quite different. I think supporting staff and developing staff over time, but also think about the stresses that running in a pandemic. But it's paying attention to it. It's thinking about time away, you know, away days, bringing together the team to think about the ways that we work and not always what we're doing. It's really sort of important investment. I think clearly horizon scanning. So in our case in particular, because our chief investigator was Susan Hopkins, who was also one of the incident directors and now is the chief medical advisor, that gives us a really good sort of horizon scanning function as well, because she has that overview of what's happening and how do we need to change. Yeah, I think that point talks a lot about kind of sort of feedback loops, collecting feedback, but it is really, you can see it as a kind of quality, it's an ongoing quality improvement, basically, and the importance of embedding this into how you do the acknowledgement that perhaps because things were built quickly, it means you didn't necessarily have the benefit of piloting them and making sure everything was perfect. So you really need to be acknowledging that we can make improvements as we go. Okay. And again, we've talked a little bit about cohort retention. And then I've, talked about this before as well, but collaboration is key. And, that really is important for us. And we recognize that quite early, the importance of, reaching out and having, that impact. And that's about bringing in different expertise and recognizing, again, we are a small team. So it's working with colleagues to really extend the reach, cohorts. So cohorts are resource intensive to run. So I think it's really about creating the infrastructure, creating the tent, and then partnering with people with expertise to really maximize the value of the data and the insights that you've got. And for SIREN in particular, that's always been looking at kind of immunology, modeling, qualitative methods. As I said, those 2 points, it's important to acknowledge, again, that collaboration doesn't just happen. You need to be proactive about it. And you also need to recognize that it can be challenging to do right. Yeah. And it does take time. And so it's just, again, thinking about that. So giving you my SIREN protection lessons. And now this is talking about what we've been doing for the last couple of years. So this is obviously, as you saw that timeline slide where sort of, I think the pandemic was declared over in sort of towards the end of 2023. So really, what have we been doing? Because as I said, it's 5 years of this study. We're still in business. So what are we looking at? So really, this slide is kind of showcasing, as I see it, some of the key distinct themes or the kind of work streams that we've been looking at, and a really big one is looking at NHS winter pressures and how COVID now is, occurring alongside, other viruses. And so that was really about the introduction of multiplex PCR testing, which we introduced for the first time in the winter of 22-23. But certainly, as you can see, these three viruses being tracked alongside each other, that was really, really done in particular in SIREN 2.0. We still have a big focus on pandemic preparedness. So again, moving out of the pandemic into preparing for the next one. Marissa, who's here, knows that we're doing a lot with kind of thinking about metagenomics with the Sanger, and I've got a slide on that. Looking at both what else drives winter pressures, but also thinking about what else is there. So this ability of detecting a new virus of concern. And then really, again, continuing that understanding of immunity, but thinking about how we extend from COVID to look at flu, to look at RSV, and lots around sort of healthcare worker attitudes and behaviours, and sort of an established qualitative and mixed methods, which I have a slide on. But just highlighting then, so this was our SIREN 2.0, so that was 23-24, where we did multiplex PCR testing on a cohort of 6,000 from our original cohort, and they also had regular bleeds as well. And that sort of gives you some numbers. So even, this is a much smaller scale, but you still end up with like 60,000 PCR tests completed by the end of it, So even for us, we're saying this is a much smaller scale, but you see it's still big numbers, okay? So I do highlight to everyone, I think this is a really it's a golden data set, the SIREN 2.0 data set. What we also did in addition to that, again, we kind of used it as a scaffold, and we did a number of sub-studies at the same time, including sort of a healthcare worker questionnaire. We started doing an evaluation of different methods of blood capture and the use of at-home versus site-based serology. We also did an evaluation of whether we could sequence directly off LFDs and do a head-to-head comparison with PCR testing. But so this is just to highlight, this is the three trends from that winter. That winter, they really did culminate in, at the same time, really. And the data that so this is the sort of headline figures there, and you can really see, I think it was like, lots more COVID basically, but again, it's how that changes by year. And then that breakdown and comparing the symptoms, we see there kind of RSV in particular had a significantly higher proportion of asymptomatic infections compared to flu and RSV. Again, we embedded throughout the study, but particularly for 2.0, we've embedded mixed methods. So that's the combination of sort of that quantitative data that we're collecting, but also utilizing qualitative sort of focus group methodology, but also doing surveys to understand different themes, as you can see. And really thinking about questions around the setting up of SIREN, attitudes around vaccination, how they've changed over the pandemic, thinking about, the impact of COVID-19 vaccine on other vaccine campaigns, but also increasingly a focus of our work has been thinking about attitudes towards staff testing and time off work. Okay. There's just one slide just highlighting this LFD sequencing evaluation. So that was a one-off cross-sectional study where effectively participants did their PCR swab at the same time as their LFD swab. It could have, this could be one that I highlighted of your challenges and problems. The key thing was by the time we'd got the kits and got this out, we basically went live when it was a very low incidence period, and sadly there was very little positivity that we detected. But in principle, this was demonstrating that you could do something like this, but ideally you would want to time it for mid-season. So this is sometimes the challenge of this very reactive, trying to do things quickly, is things are outside your control. But you can understand the reason why we're looking at that is, obviously LFD is much, much cheaper than PCR, right? If you can sequence, if you can sequence off LFDs, this is a hugely important tool for being able to understand variant emergence over time and all of these things. Because obviously if you switch completely off the PCR and you're just doing the LFDs, you lose all those data points, don't you? So this is a really valuable thing to think about. Can it be done at scale? So as nice, Marissa's in the audience, this is a slide that Marissa shared earlier about, I think, one of the early cuts of the panels. But so this is with one of our key partnerships we started in 2.0 was with the Wellcome Sanger Institute, with Ewan Harrison's team. And we have two collaborations, and I'll talk about this one in particular. So this one is utilising all the stored VTM samples that we had. And the first question we started is looking at what viruses contributes to winter pressures in the NHS workforce beyond those three that we're testing. So what else is there? Yeah, and so that's ongoing work, which is quite exciting. We also had an ongoing partnership with the CRIC, which we established quite early on, but this was also the CRIC and the World Influenza Centre, and that was utilising again the multiplex PCR that we did, and that stored four time points, that's serology, and the CRIC have developed high throughput neutralising antibody testing for influenza, which is a new pipeline that they had, and obviously part of our partnership with them was because they developed that capability for COVID. But that's allowing us to look at questions about different vaccine responses and also looking at currents of protection And just highlighting, we also have done a vaccine effectiveness analysis for the flu vaccine campaign. And our next focus is looking at RSV. And this is just, again, so this is highlighting SIREN Plus, which is our this winter's iteration. So our cohort of 5,000 have just finished this testing. We certainly didn't secure budget for ongoing testing, but this highlights that there you've got a group of participants who are very active and willing to contribute to a surveillance function, which is this one. So this was just tracking symptoms and tracking time off work, which again are valuable insights. And actually we have some ongoing work where we're actually working with health economists to assign a cost to this, because partly costing out the burden of staff illness due to respiratory viruses over winter also hopefully directs the minds of what you could invest in interventions, which as a team is our sort of next function. Is how do you stop how do you reduce the transmission of respiratory viruses over winter in healthcare settings? The second study we've got with UN is moving back to our core function within the Healthcare Associated Infections and Antimicrobial Resistance Division. And so this is looking a slightly new focus, but still about swabs up the nose and the mouth. But this is looking at understanding Staph aureus carriage and understanding the nasal microbiome in healthcare workers. And this is also about sort of supporting work that's already in train that Ewan and team have been looking at with the carriage study, which is looking at blood donors. And they've also got a project with Russ Hope as well, which is working in UKHSA, which is looking at bacteremia cases as well. So it's about coming in here with all of that rich data and saying, does it look different in healthcare workers? Okay. And so that was, again, a start of 250, where, again, we had sign up, within 12 hours, we had, so people were really, really keen to be engaged, which is brilliant. So briefly, that is my kind of Venn diagram of where we are with SIREN. I think the box, I start with the team, because the team is key to everything. Our skills, expertise, and our ways of working. Our cohort of healthcare workers, the networks and the collaborations, and our biobank and our data. And so this is a big focus of us as a team. And then these Venn diagrams are the sort of different topics, the preparedness, immunity and vaccines, NHS pressures and workforce, and then thinking a bit more about antimicrobial resistance. So concluding remarks, ongoing data collection. We've been running for 5 years. We're still in business. We were established early in the pandemic to deliver priority research at that time on reinfections and vaccine effectiveness. And I've talked about how we sort of delivered on that, both through that surveillance function, but also those analyses. But we broaden our remit post-pandemic to address public health priorities and chiefly winter pressures and pandemic preparedness, but also broader than that. And my key lessons from SIREN / and research network, learning from other studies. Be pragmatic, adapt, involve participants, care about the how, and collaborate. And on that note, I should just highlight, big thank you to lots of people. I know I'm standing up here talking, but there's clearly huge amount of effort from lots and lots of people. This is very much just the current team. We've had lots and lots of people who've contributed to running SIREN over the last few years, and lots and lots of people, as we said, with the collaborations and making it possible. So thank you very much.